Welcome, and thank you for joining us for today's discussion, what CMS's mandatory team model means for hospital leaders and what to do before 2027. Before we get started, here are a few quick notes to help you stay connected and informed. Following the webinar, we'll send a link of the recording to all registrants so you can revisit the conversation or share it with your team. At the end of the discussion, a short survey will appear. It only takes a moment to fill out, and your feedback helps us shape future conversations that deliver the guidance and clarity you expect from Hub. And now I'd like to introduce our moderator for today's event. Pete Riley, North American Healthcare Practice Leader at Hub International.
Good afternoon, everyone, and welcome to our webinar, what CMS's mandatory team model means for hospital leaders and what to do before 2027. I'm Pete Riley, Hub's North American Practice Leader for Healthcare, and I'm joined today by two outstanding colleagues for what I think is one of the most important conversations in healthcare risk and financial management that can be had right now. A quick word about Hub. We're leading global insurance brokerage and financial services firms, ranked among the top brokerage firms globally. We help organizations not only manage risk, but we help them to build the kind of resiliency that holds up in an uncertain environment, much like we are experiencing today in the healthcare world. Today's session reflects exactly that commitment to try to keep our clients, prospects, and friends up to date in order to make them more resilient. CMS, as all of you know, the acronym for the Centers for Medicare and Medicaid, their new mandatory team model represents one of the most significant shifts in healthcare payments in years. And many hospital systems are still in the early stages of understanding what this means for them. Our goal today is to change that. By the end of this session, you'll have a clear picture of what team requires, what's at stake if you delay, and a concrete readiness framework that you can act on immediately to get your organization ready. Helping me to unpack all of this, and two of my colleagues and friends are first, Christina Howard, Enterprise Risk Management Leader within Hub's Complex Risk Practice. Christy helps healthcare organizations develop enterprise-wide strategies that address governance, compliance, and operational risks, and she brings that exact lens to our discussion today. And Corey Jorbin, Senior Vice President and Employee Benefits National Director of Compliance Consulting at Hub. Corey is one of the sharpest compliance minds in our business, and he brings a critically important perspective on how the workforce stability and employee benefit strategies intersect with team performance. Together, the three of us hope to bring, and that you will learn from, a multidisciplinary view of what team really means across financial risk, governance, and the workforce dimensions that most organizations miss entirely. Here's what we will cover today. We'll start by setting the stage, the context behind where team came from and why it matters now. From there, we'll walk through what team requires, model mechanics, episode definition, quality metrics, and the reconciliation process. Then we'll get into the ripple effects, because this program is not just a compliance challenge. It touches on finance, HR, governance, and legal liabilities in ways that most organizations haven't thought through yet. After that, we'll bring the risks to life through three illustrative scenarios drawn from common organizational patterns. We'll close with a practical readiness framework that you can take back to your team, and we'll end up with some Q&A. Before we get started, several of you have submitted questions with your registration, and we'll do our best to address these as time allows. But let's get started with the meat of what we're here to discuss. And grounding the conversation, let's get some context. The team program didn't just come out of nowhere. It is the next step in a decade-long trajectory that has been moving healthcare payments in one direction. That direction is mandatory provider financial accountability. To understand where team is taking us, it helps to understand how we got there. For more than a decade, CMS has been systematically shifting financial risk from payers to providers. We've seen this trend across many cost-cutting and shared saving programs, from bundled payments for care improvement initiatives to accountable care organizations. Each of those models was designed to test whether providers could take on the financial accountability for the cost of quality care. They were voluntary. The TEAM program is different. It removes the choice. It is the next step in the trajectory, and that direction of travel is very clear. Mandatory accountability is the future of healthcare payments. If your organization has been watching value-based care from the sidelines, waiting to see how it plays out, that option is gone. So what do the next step looks like? Let's talk about what TEAM actually is. Like most government programs, everybody loves a good acronym. TEAM stands for Transforming Episode Accountability Model, is CMS's latest mandatory value-based care initiative. It holds hospitals financially accountable for the full cost of quality and care across a defined episode, not just the hospitalization itself. But this responsibility goes across the entire continuum from the anchor procedure through post-acute recovery. Some key features of what the TEAM program is the episode scope. These are high volume, high cost episodes, joint replacements, cardiac procedures, and select surgical episodes. The accountability window. This extends beyond the inpatient stay at the hospital through the post-acute recovery. And participation, not determined by your organization's preference. It's determined by your geographic designation. If your hospital is located in a designated metropolitan statistical area, or MSA, you're in. There is no opt-out. Now that you have a more clear picture of what TEAM is, let's talk about the timing, because that's where the urgency becomes real. Mandatory participation begins now. Over 700 hospitals are already operating under the program. Currently, in year one, this has only upside potential benefit. That changes in 2027. And the preparation that TEAM requires cannot be compressed into the final months of 2026 before the downside risks kick in. What does this readiness demand? 4 essential components are financial modeling, compliance infrastructure, a governance framework, and cross-departmental alignment. This work takes time. The organizations that have been building now have options. Those organizations that wait will find themselves making reactive decisions under pressure with a limited runway to close the gaps. Every month or delay narrows that runway. I'd like to invite Christy to add some early context here as to what she's seeing from a governance and enterprise risk standpoint in terms of where organizations are currently, what stage they are in their awareness, and how and where they are in that timeline, and how they're preparing. Christy?
Thanks, Pete. What I'm seeing right now is that most organizations are aware that TEAM is coming, but awareness is not the same as readiness. The challenge from an ERM perspective is that TEAM is being treated as a compliance issue or a finance issue rather than the enterprise-wide risk event that it actually is. The organizations that are ahead of it are the ones that have already started cross-functional conversations, bringing compliance, finance, HR, and governance into the same room. Those conversations will take some time to have and even more time to act on. So the 2027 deadline is a forcing function, but the preparation window is right now.
You know, Christy, that's exactly right. And that's really one of the threads we're going to be pulling on throughout this session. Let's get into the mechanics and explore what exactly TEAM requires of your organization. Before we do, Corey, do you want to add a hint of what you will discuss just a bit further down the road in our framework?
Sure, thanks, Pete. So I'm going to be touching mostly on how this relates to HR, just because even though at first glance this might not seem like an HR related issue, it absolutely is. And I think a reoccurring theme that we're going to touch on is some of the downstream effects that this could have on employees too. So I would say, Christy, to your point, this is really an enterprise-wide requirement, and there's a lot of other effects that this will have throughout the organization.
Thanks, Corey. Now let's get into what it is, as I said, the teams, the core metrics thereof. Here's how the model works at a very high level. CMS is establishing and has established for the existing hospitals episode cost targets for each defined clinical episode. These are based on historical spending data, adjusted for the case mix at a respective organization or facility, geographic, and quality performance factors. At the end of each performance period, like with many other value-based care contracts, that period is set and defined. But at the end, CMS will reconcile your organization's actual episode spending against those targets. If you exceed the targets, meaning your episode costs are higher than the benchmark, you may owe repayment obligations to CMS. This is not unlike, as I said a moment ago, existing value-based care contracts. However, in year one, right now, this is only upside, which, as I mentioned, if you perform favorably, meaning your costs are below the benchmark, you may be eligible for shared savings. But, and this is a critical component, like the mandatory aspect that we were talking about, the critical component that the shared savings are subject to quality performance thresholds. Cost and quality performance are linked. You cannot optimize one without the other, and this is a significant change. Now that you understand how the model settles performance financially, let's look at the clinical episode, which clinical episodes, actually fall within team, because this is where many organizations get their first surprise. Team currently includes lower extremity joint replacements. These encompass hip and knee replacements. It includes cardiac episodes, specifically coronary artery bypass graft procedures and surgical aortic valve replacements. It also includes select additional and medical episodes as further defined by CMS. So if your organization is either currently participating or expects to participate, it is crucial that you understand those additional surgical episodes so that you are addressing and the entire risk that you are encompassing within your organization. Christy.
Could I just add a quick comment there? This is a piece that catches organizations off guard. Each episode is not just the anchor hospitalization that you were mentioning. Each episode also includes the anchor procedure plus a defined post-acute period. So that means that your hospital is accountable for the cost incurred across the full episode, including care delivered by skilled nursing facilities, home health agencies, and other providers. They are not part of your organization, but if your post-acute partners are not performing, it shows up in your numbers. So understanding which episodes are covered is only part of the picture. The other dimension, and the one that has direct financial consequences, is the quality performance.
Christy, you read my mind, because I could tell you had a comment to make, and I wanted to be sure that we got to that. Thank you very much. That quality performance that Christy just mentioned is not a secondary consideration under team. It is a financial lever. Quality thresholds must be met to access shared savings. The metrics span clinical outcomes, patient experience, care coordination, and process measures across the full episode. And as Christy rightly pointed out a moment ago, you do not have full control within your facility because your post-acute care program is a part of this overall team program. That is a key distinction as we move forward. But here's what makes this particularly consequential. Failure to meet the quality thresholds can eliminate your shared savings entirely, even if your cost performance are favorable. And quality underperformance can trigger additional financial penalties. This is an integrated performance model, which makes it so separate and distinct from so much of what has been seen before.
Pete, I'm sorry, could I interrupt you one more time?
Please do.
Another quick point here. This is sort of an overarching thing that I can't help but point out. Hospitals historically have operated in a financial model that does not have any downside potential. It's been provide the service, bill for the service, get paid to an extent for the service. Now there's going to be a potential for actual financial loss.
And with that reality, and thank you, Christy, because again, that point cannot be understated. The ripples to something like this, and this is one of the key portions of this webinar we wanted to include, Corey, are the things that we should talk about, that the boards and the CEOs and CFOs and the head of HR should consider from a workforce and benefits compliance perspective, and how the quality of performance is affected by this workforce dimension.
Yep, absolutely. So I guess the first thing I think of here is obviously because quality and costs are tied together. Sometimes we might have heard about hospitals being quick to discharge patients. I feel like that goes away with this, because I think that hospitals are going to need to strike a balance between, managing costs, but at the same time ensuring quality. But from an HR perspective, I think that obviously HR very much needs a seat at the table. They need to understand what the obligations are for the organization so that they can ultimately help the organization's staff to ultimately comply with the team requirement. So as part of that, that could mean hiring additional people in additional roles, for example, care navigators and care coordinators, or possibly taking people that maybe they're in another role currently and adding to their duties. So this is where HR is going to be incredibly important. And from a benefits perspective, one of the things that I'm personally concerned about is, given the negative implications of potential having downside here financially, could that ultimately impact staffing levels? Could that impact stress levels? And then could that impact benefits? Is there going to be a situation where a hospital might have a negative downside financially because of this, and then all of a sudden they have to make changes to their benefits? I think that's certainly possible, as we see this kind of come to fruition.
Corey, and that's a great point. That workforce strategy is not a soft HR issue in the context of team. This all has interconnected direct financial consequences. And you mentioned burnout and high turnover. These are challenges that the healthcare industry and care delivery providers already face when you overlay the existing financial challenges that team could present. I think your point, Corey, is an excellent one, because it is either going to compound an existing challenge, or there's an opportunity to really get out front to this, and instead of being reactionary, be ready to how you want to deal with your workforce, because they are going to be integral in this entire process. We'll come back to this for those of you in the audience, the workforce connection, in just a few minutes. But before we do, I want to talk about the reconciliation process, because understanding how CMS is going to measure and then settle that performance and anticipating your financial condition thereafter is going to be critical as you continue to explore how your organization can handle team. Understanding that process, that reconciliation process, is essential. Organizations that don't understand how they're going to be measured can't anticipate the financial outcome or identify the discrepancies in order to protect that outcome measurement. Here's how the reconciliation process works. CMS reconciles episode spending against the benchmarks periodically throughout the performance year. We talked a few moments ago about how those benchmarks are established. It is critical that you understand how they were created, and then the part about where they're periodically evaluated throughout the year becomes essential, that you understand that's your opportunity to measure where you are before a year-end reconciliation is done. As I said, the methodology accounts for risk adjustment, attribution, and outlier exclusions. And that's important to understand what those are, so that you are not preparing for the wrong potential facets that will impact your reconciliation. Also, there is a dispute resolution process that has been built in. It does exist, but it requires preparation, documentation, which we will talk a little bit more down the road, and many organizations have not yet built this in, even as they may be preparing for the team program. Christy, from an enterprise risk standpoint, and we will refer to that several times as ERM, so that everybody's on the same page, what should organizations be doing to prepare for this reconciliation effort?
Pete, I think the name of the game here is rigor in documentation. Organizations will need to understand the reconciliation methodology well enough to know when something looks wrong and to have documentation in place to support a dispute should one arise. That means building internal processes now before performance measurements begin. And the organization that treat reconciliation as a passive process, just waiting to see what CMS sends them, are the ones that get surprised. The ones that treat it as an active risk management function are far better positioned.
And that, I think, is another theme. And if you haven't picked up on this, dear audience, there are some central themes in a very complex process that we want to leave you with today that you can continue to use as the foundation for part of the framework we're going to show you. But if you get too far afield from any of these key aspects, that active risk management function that Christy mentioned, the workforce resilience and considerations that Corey mentioned, these are going to continually be necessary in order to make sure you are best prepared for the team program. But at this point, having talked about the reconciliation and the active risk management, as Christy just alluded to, I want to close this section with something that I think deserves to be said over and over and over. This program has mandatory participation. Participation in teams is not optional. It is determined by your MSA designation. And if you're not sure, you can find out that information at the CMS website. But this is not an organizational preference. Your readiness level for your financial situation is not an opt-out eligible decision for hospitals. Non-participation is not a neutral position. It carries its own regulatory and financial consequences. So the question your leadership team needs to be asking is not whether to participate, it is how well prepared your organization will be when the participation and its full ramifications of downside risk begins. As Christy said, organizations that treat this as someone else's problem or a future problem will face a very different 2027 than those that are building for readiness now. So now that we have some basic understanding of team and what it requires and how the mandatory participation will require a financial reconciliation, let's talk about the part that most organizations haven't fully thought through yet. And that is what we're calling the ripple effects. This section, the ripple effects, is a section I want every CFO and CEO and board member in this audience to pay close attention to as as more than just a clinical or compliance issue, challenge, or problem. It is not. Teams is an enterprise-wide risk event, and the ripple effects go further than most organizations realize. Let's start by reframing how most organizations are thinking about this, because the framing matters. The team model requirement creates a downstream consequence for every major function of your system: finance, compliance, human resources, risk, and governance. No single department can own this. No single advisor or internal person can be the lone champion. This cannot exist in isolation. And so let's take a look and go through each dimension that we believe is vital. Let's start with the two dimensions that tend to get the most early attention: finance and compliance. The regulations, rules, and all that encompasses finance and compliance can go in 1,000 different directions. But when we talk about the challenges within team and how that equation has to really be thought of carefully and thoroughly. This is a slightly different approach and one within an ERM framework. Christy, of course, because it's ERM, I'm going to hand it to you.
Thanks, Pete. Great. So first, from the finance perspective, team changes the budgeting and forecasting equation in a fundamental way. Organizations now have to account for potential reconciliation repayments in their financial planning. Capital planning must reflect the performance-based revenue adjustments. So financial modeling for multiple performance scenarios is no longer a best practice. This is table stakes now, a baseline requirement. On the compliance side, team introduces new documentation and reporting requirements, and those demand robust infrastructure. For example, coding gaps don't just affect quality scores, they'll affect cost calculations, which in turn affects your financial reconciliation. Audit readiness has to become a foundational expectation, not something you think about when the auditor shows up.
You know, Christy, I find the lead with finance and compliance is a natural decision from either a C-suite or board at a hospital. But so often, a piece of this that gets overlooked, and as you rightly point out, the foundational aspect of finance and compliance, but is how those decisions, these decisions that they are making, impact the workforce. And we alluded to this a few moments ago in our discussions. Corey, the ability to address this often overlooked aspect is right in your lane. Let me throw it to you for a moment.
Thanks, Pete. So I would say this absolutely goes over to HR for a couple of reasons. So first and foremost, HR is going to have to help the organization meet their staffing needs. And this can involve a lot of different moving pieces. For example, we already talked about possibly needing to add or repurpose existing employees. If we're adding, say, care coordinators, how is that going to impact potential other HR needs? So are we going to be taking from, one hand and moving headcount over to another? I think that's quite possibly going to be the case. So in terms of that, HR is obviously going to need to be very involved with that and then work within the organization. But at the same time, we're also really concerned about the current employees too, as well as employees that are added in terms of managing their stress. Because Pete, you've already mentioned that, of course, everyone in healthcare is stressed. It's not a new issue. I think that this is certainly going to add to that within the organization. So how is HR going to help their employees? Are they going to, say, add mental health resources or, make sure that employees know about the availability of their employee assistance program or EAP? These are just a few different things that employers can do to ultimately help support their employees in, managing stress generally and their mental health, but then also obviously all the new stress associated with the team approach.
Yeah, thank you, Corey. The connection between your benefit strategy and team performance is one of the most underappreciated facets in this new world. And while oftentimes HR and finance do not always have direct dialogue, I think you'll see that more and more, and with some examples we're going to give a little later on, this becomes, again, to steal one of Christy's phrases a moment ago, this is becoming table stakes within the larger organization because the financial implications can be significant. Now let's turn to the dimension that has the most direct personal accountability implication for the leaders on this call: governance and legal liability. Christy?
Thanks, Pete. I really want to speak directly to any board members and senior executives in the audience because this information is for you. Boards carry fiduciary responsibility for organizational preparedness under team. So team is a known mandatory regulatory requirement, and any documented inaction creates a governance risk. Further, failure to establish adequate oversight frameworks won't just create a financial exposure. It will create reputational exposure and could undermine your enterprise risk posture. Organizations that treat team as an operational manager like delegating it entirely to compliance or finance without the board level visibility, are carrying unmanaged enterprise risk. The board needs to be in this conversation, and it needs to be in it now, Pete.
Christy, that point about documented inaction is really important. And it's almost a misnomer, documented inaction. But I think that's, a nice way of saying if there's no evidence that it was considered, there's no evidence that it happened. Can you say a little bit more about what this means practically for these hospitals and these health systems?
Yeah, sure. So from an enterprise risk management perspective, when a known risk is identified and no action is taken, that inaction becomes part of the record. If something goes wrong under team, such as a significant reconciliation repayment or a regulatory inquiry or a payer dispute, and there's no evidence that the board was aware of and actively overseeing team preparedness, that creates a real exposure for board members and senior executives personally, not just for the organization, personally. The goal doesn't have to be perfection here. It's really about demonstrable oversight, and you can only demonstrate it if you start the conversation now.
Christine, that raises a facet that we do not have a great deal of time to discuss here today. But as she alluded to, the lack of action that can lead to senior executives personally being somehow liable through any allegations that might be covered under your directors and officers liability program, as Corey alluded to, the stress and other facets within the workforce. This brings into the picture a little bit of what we will call management liability exposures, i.e. D&O, employment practices, and even cyber liability, because as was discussed previously, when you're responsible for the care through post-acute, you own the medical records and all of the facets that come with this. And as Christy said, if you fail to show evidence you've considered and tried to act as a good fiduciary, the ripples to this and what can happen to the board need to be carefully considered, because they can be incredibly detrimental. And so while we don't have time to run down this entire total cost of risk and ERM approach, please know that it is there, and we're happy to answer any follow-up questions on that down the road. So if that hasn't scared enough of you right out of the gate, we've talked about the framing of how this needs to be done. Let's spend some time talking about the mechanics of the ripple effect. And now let's make this concrete. We want to walk through 3 illustrative scenarios that hopefully will bring some of these risks to light. Again, we don't want to scare you into this. Our intent, our hope, is to educate you as to the seriousness of all of this, the overlooked aspects, such as Corey has been talking about, but really, we hope this part will begin to make it tangible. You can begin to ask yourself how your organization is prepared, but it may also lead to further discussions, and we'll talk about the framework we think that can help do something about this, as opposed to just trying to scare you about this new CMS program. So let's look at some slides that talk about the various ripple effects made real. The potential scenarios we really think can fit into 3 categories, but let's start with what I will call the financial modeling gap, the clinical performance blind spot. Let's use as an example a 250-bed community hospital in the designated MSA that performs a high volume of lower extremity joint replacements. Leadership within the hospital, from the board to the C-suite to the physicians, has a strong clinical outcomes and assumes that will translate to strong team performance. It's a reasonable assumption in one respect, but sadly, it's also wrong. What can go wrong and where this can really have a detrimental impact with team is if there is no financial modeling conducted against the CMS episode cost benchmarks. As I mentioned earlier, those benchmarks are determined by a number of aspects, but a failure to understand them for your MSA is going to create a potential gap in understanding what those exposures may be. And this speaks to what Christy was alluding to just a moment ago. But unmanaged skilled nursing facility utilization or other post-acute spend that is being driven well beyond the norm and above allowable levels will create further gaps and potential downside risk for you. At the first reconciliation of this particular example, let's say the costs run 12% above the benchmark. The result could be a 7-figure repayment obligation not anticipated in the budget. Back to the lack of financial modeling, this might become completely unknown. And a compliance conversation as a result of this that the board was not prepared to have. And so the ripples to this financial model, because of a sole focus on the clinical aspect, do create problems. And specifically, that gap is no financial exposure modeling, no post-acute care coordination strategy, also an often underlooked aspect of what this could be, and no board level awareness of the risk. I think that gives a pretty fair summation of those key facets that simply by not knowing what the models are, create a risk for you. This scenario is not hypothetical in terms of its generalities. It's a pattern that we see repeatedly, but it is also entirely preventable. So this first scenario illustrates what happens when financial modeling and post-acute care coordination are not made critical and they fall through the cracks. Our second scenario is going to shift the lens to governance and to the exposure that come not only to the organization, but to the board itself when these boards are not included in the conversation. Christy, this is right in your wheelhouse.
Certainly is, Pete. Thanks. I think this scenario will hit closer to home for a lot of boards, a lot of board members. It illustrates a potential governance blind spot. In this case, a regional health system begins team participation without ever formally briefing its board on the model's requirements or financial implications. So senior leadership treats team as an operational manager. They may delegate it to compliance and finance, but without board responsibility or, equally important, board visibility of the model's ramifications. And then let's suppose during a routine audit, a significant gap in documentation is surfaced. That affects both quality scores and cost calculations across multiple episodes. So this is starting to get hairy. A payer dispute follows, and then the board is asked to respond to questions about its oversight of team and team's compliance, but board members are unable to demonstrate that adequate governance frameworks were ever in place. So there's no way to demonstrate they had their eyes on it, that they made plans, and that they were following up and monitoring the success. So the result here, there's a strong probability for reputational damage, possibly a regulatory inquiry and management liability questions that Pete mentioned earlier. That could have been entirely avoided with early governance engagement. So let's recap the gaps here. So there was no board level briefing, no governance accountability framework, no enterprise risk oversight of team compliance. So we get governance gaps across the board. But the good news is there are solutions to the governance gaps and preventive measures that can be put in place right now. This is one of the scenarios I think about most when I work with healthcare organizations. The financial consequences clearly are very real, but this governance consequence can even be longer lasting.
Thank you, Christy. The governance blind spot is really preventable and made all the more important because it is so consequential. But let's move to our third scenario that adds another layer of complexity and particularly relevant for organizations already participating in value-based care arrangements. We had a question come in, and that says, how does teams interact with our existing ACO arrangements? And so we will go through this fairly quickly because I think that question is fairly straightforward. Several of those organizations, those 700 plus hospitals that are mandated in team, may already be participating in one or more of the shared savings arrangements. Leadership views teams as incremental, similar to what many they've managed before. And team is an added risk portfolio without anyone really having responsibility for it, again, in the cross-cultural, cross-departmental need. What happens is you get a below average performance year, and this hits most of the various contracts. The long and short is there's a repayment obligation triggered. Clawbacks under other shared arrangements are done in coordination with and compounded with teams. We refer to this, as it says at the slide heading, the compounding risk problem. Long story short, the combined financial impact significantly exceeds any contingency reserves or other planning. The gap, that there was no aggregate value-based care risk modeling. That becomes all the more important, really speaking back to scenario number one. There was no stop loss or reinsurance strategy. This is a complex placement that can be done, but also can be a lifesaver for an organization financially. And there was no cross-program risk monitoring. They do not exist in isolation or in silos. They really do compound one another, for lack of a better phrase. And that's the critical takeaway. Team doesn't exist in isolation. It stacks on whatever VBC exposures you're already carrying. Understanding this exposure is critical, not optional. Corey, from a workforce standpoint and a benefit standpoint, what role does this workforce instability play in the performance? And you alluded to it a little earlier, but I want to bring it back here because all these various financial models require quality outcomes, and that requires staff.
Yep, absolutely. So obviously the more turnover within an organization, the higher the training expenses for that organization. But one thing that I'm particularly concerned about here with these negative implications, specifically if there's a negative downside and that it wasn't properly modeled from a financial perspective, is that all of a sudden it could force the organization to have to make benefits changes. If you're changing benefits for the worse, which would likely be the outcome here, that's not going to go over well with employees. So now all of a sudden you'd effectively be, I would say offering them benefits that aren't as good or maybe cost more than they had in the past. And I feel like that's just going to overall hurt employee morale. At the same time, we've seen this work out positively for employers where maybe there's an unexpected upside and then they look to enhance benefits. So I feel like this can go both ways. It's just obviously important from a planning perspective that employers understand what they need to be doing so that they're avoiding any financial downside.
Thanks, Corey. Well, we've just talked about three scenarios, three different gaps, but a common thread running through all of them. Organizations that aren't treating team as a cross-functional, enterprise-wide priority and carrying exposures that they can't see are unprepared. But now let's talk about how to close the gaps. As we promised, we're going to give you some sense of what can be done today in order to begin to address this issue. So we're calling this and speaking to the readiness framework. That is the ability to evaluate what you have in order to know where you stand and then what process needs to be taken. The good news is that if you're starting now, you have time to do this correctly. The readiness framework we're about to walk through is designed to give you a clear sequenced path from where you are today for where you should be before 2027. So let's jump right in. We've organized these into 4 phases, and I'll walk through each one at a high level and then invite Christy and Corey to weigh in. Phase 1, foundation, establish governance. And Christy talked about the importance of the need to have the board involvement early. Assign ownership. This is what we talk about with the cross-functional need. You have to include finance, HR, compliance, risk, all the way down to every facet of the organization needs to know what's at stake here. And when appropriate, engage outside advisors to help you explore how each of these aspects will contribute to the foundation and needs to become a part of it. Phase 2, the assessment. And this one may be the most important because I believe traditional ERM and most hospital organizations understand the foundational need to coordinate to some degree, but this requires more. The financial modeling that needs to take place, not just within the finance department, but across HR, as Corey alluded to, becomes absolutely vital. Conducting a compliance gap analysis is really vital to begin to understand where you are exposed. It's not necessarily quick and easy, but it can be determined. And lastly, creating those quality benchmarks that are needed from clinical, operational, finance, and benefits from a benefit standpoint all need to be discussed, because as you understand the gaps and the model and what you're going to be measured against, you can then set benchmarks that work for your organization. Phase 3, the infrastructure. Work to close those gaps identified in phase 2. Cannot stress this enough. Absolutely needs to be done. Build monitoring programs like anything else. When a patient has started their episode, proper monitoring of those ultimate customers we serve, the patients, same is true with the team program. Build in monitoring programs so you know how you are performing. And lastly, align your workforce strategy. We are going to continue to hit on this as you talk to us in any aspect of this overall program development. Your workforce strategy must be aligned, because this will have impact and ripples across the organization. And you want your team, you want your providers, all the way down to the people greeting your patients coming in the door, to understand how important this is. And phase 4, pre-2027, this is when the downside risk sets in. Full enterprise readiness review. Conduct it even if you think you're ready. It's just as they said when you were back in high school, go back and proofread. Show your work and let others look at it so you can make sure that you are ready for this to happen. Get board sign off. I think Christy has made that point very clearly. And process testing before the compliance window opens. This is probably the most time consuming, because you have to make assumptions, review those assumptions. How would they actually be designed and used in your organization becomes vital. So go back and confirm all of this so that you can then make last minute corrections as needed. Christy, Corey, anything you want to add on that front?
I would only add that the clock is ticking, and any time that you spend preparing and planning will pay off immensely. I'd like to be clear about how this sequencing works, not to skip the phases. And Pete, maybe you'd like to expand on this a little bit, but if you're trying to jump right into phase 3 without the foundations in 1 and 2, you'll find yourself revisiting those gaps at the worst possible times. So start now, start at the beginning, go all the way through.
Yeah, the 4 phases, as Christy alludes to, they give you the sequencing process. And again, we've tried to keep this simple at this point as to what we can fit into this time constraint. But before we move on to the final assessment, what we need to do is make sure that you go back, evaluate each step. If you need to step back to the most important at phase 1, please do so. But it is vital that you do these steps not only appropriately, but be sure you conduct them thoroughly, because it shapes how you should be thinking and about everything that you will need in order to be ready for team when it has its full ripples throughout the organizations on upside and downside risk. And it's a great deal, a great process to really go back and review everything that we've covered today. But here's the most important strategic insight that I want to leave you with. Team creates simultaneous exposures across the 3 domains we've alluded to, and that rarely work together: finance and regulatory, risk and employee benefits, and workforce stability. And it creates an absolute need for enterprise-wide coordination in order to be ready to prepare for this. Rather than be reactive, the framework we've laid out, and we've done so quickly, and again, we can have further conversations, reach out to us after this webinar, There are steps that can be taken, and we need to help you get there. So please ask. Sadly, most organizations manage these through separate advisors. The risk manager may not talk to HR about how this is going to coordinate with one another. The HR and benefits team may not involve their ERM function. That too leaves a gap. And the ERM function doesn't have a seat necessarily at the contracting table. And as we alluded to, the post-acute care, what are the agreements and arrangements that are made with those organizations? Because they will have ripples across the team program measurement and reconciliation. Sadly, the result of traditional operations is that no one has a complete picture of the aggregate exposure. The framework we've just described is intended to begin to give you the benchmark basis foundation with which to create that overall and better coordinated effort. Organizations that are best positioned to navigate team are those that bring these disciplines together sooner rather than later. And Christy, we've alluded to it, but can I ask you to speak to how ERM creates that connectivity tissue for a challenge like this?
Yeah, definitely, Pete. You know, ERM in itself, in its whole characteristic base, is specifically designed to identify these interdependencies between risks and create a unified view of organizational exposure. So absolutely everything in one profile. This also puts organizations in a position to connect the dots and manage risk more effectively. So for team, this means bringing financial modeling, compliance infrastructure, workforce strategy, and board governance into a single coordinated framework. The alternative, managing each of those dimensions separately, is how you end up in a situation like scenario 3 that Pete shared with us. The organizations that will truly succeed under team are the ones that treat it as the enterprise-wide risk challenge that it is, rather than a series of departmental to-do lists.
So Corey, anything for you from the EB standpoint that the connective tissue that can be done to help complement the ERM effort?
I think what really stands out here is that we're taking all these organizations or departments within an organization that are used to working on their own in their own silos, and now we're asking them to move outside their silos to work together. I think that's absolutely the right plan and the right plan of attack here, and that's because, as you both kind of highlighted, if each department is operating independent of the others, we're going to duplicate work, we're not going to be efficient, and then we're also going to ultimately end up with kind of a hodgepodge of a plan. And then Christy, going to one of your earlier points, you mentioned gaps, and I feel like when you're not working together, that is ripe for a scenario that leaves a lot of gaps because we're not accounting for everything and how it applies across the organization.
Well said, both of you. That the failure to coordinate really undermines an organization's team readiness. And that's one of the keys we want to make sure is understood today, but there are things you can do about it, thus the framework. Let me begin to close with 5 questions that we put together that I think highlight what we've discussed today. And these questions are a simple initial self-assessment, because the best way to know where to start is to understand where you are at this point in time. The 5 questions that every leader on this webinar and every leader within your organization should be able to answer are: number 1, have you identified which of your clinical episodes fall within the team parameters? Again, easily determined by visiting CMS, and then easily determined by what you have actually done. 2, have you modeled your financial exposure under different performance scenarios? If the answer is no, I'd strongly recommend you consider it. 3, does your board have visibility into your organization's team readiness status? As Christy alluded to, they can become dragged into this should there be a negative, a downside risk situation. So please make sure they are aware. 4, do you have cross-functional ownership of team compliance across clinical, compliance, finance, HR, and risk. If there's one person who may handle one or two of these, it makes it all the easier, but you must get that cross-functional ownership. It cannot be one person. And 5, have you engaged outside advisors with the right expertise to help you to close this readiness gap? And that goes from risk and insurance to legal, to accounting, to actuarial. These are the folks who can help you in this effort. If your answer to any of these is no or not yet, that's your starting point. Because we are pushing late into this, I want to thank both Corey and Christy for their time and say, are there any final thoughts that either of you would like to share to make sure we leave a foundational piece for everybody on this call?
I would just have a couple of closing thoughts, really reflective of those 5 questions in the self-assessment. Again, boards are often the last to know what's going on with team. And throughout the discussion, I hope that we've underscored creating real governance exposure can happen easily if the board visibility is not where it needs to be. And that's probably the first thing that I would address. The other component is the cross-functional alignment that is equally critical. Cross-functional alignment is a hallmark of good enterprise risk management, and it is absolutely essential here.
Corey?
And I'll just quickly highlight the use of outside advisors. This is something that we constantly tell our clients in the employee benefit space. Use your experts. You don't have to be the experts in everything. There's a lot of different experts at your disposal, and don't hesitate to bring them in to help with this process.
2 great perspectives, and that I think really highlight the theme. Team preparation requires the whole organization, not just one department. The organizations that can answer yes to all 5 of these questions are in a strong minority right now, but that's exactly why we're having this conversation. And for those who can say yes to all 5, we congratulate you. I'm sorry to say that we're pushing time and we do not have time to get to any additional questions. We tried to weave some of them into these conversations. We will be reaching out to those of you who have asked them to try to answer those questions specifically. So please be on the lookout for that. But overall, this brings us to time. I want to thank Christy and Corey for an outstanding discussion today. And I want to thank each of you for spending a part of your day with us on this important topic that is not going away. Here's the basic message I'd like to leave with you. The team is mandatory. 2027 deadline is real for the downside risk, and preparation needs to be made now so that your organization that can act between now and that deadline can be in a fundamentally different position than those who wait. The gap between prepared and unprepared is widening every month. If you have specific questions, please reach out to your Hub representative or visit our website at hubinternational.com. Your follow-up email to this webinar will include a link to this recording. A very quick note that we have 2 additional events upcoming that may be of interest to you and your team that speak to some of what we're talking about here. On June 10th, we are going to have a webinar on the state of global benefits, trends and risks, and what employers need to do now. This is where Hub's global benefits experts will look at macro trends reshaping employee health and benefits for larger employers. And then on June 24th, breaking the cost cycle, taking control of your healthcare cost strategy, very much in line with what Corey was talking about. This is a practical session on managing rising healthcare costs from GLP-1s to gene therapy to high-cost specialty drugs. We'll include more detail about these upcoming webinars in the follow-up email. And lastly, before you sign off, please take a moment to complete the brief survey that will appear on your screen. Let us know whether today's topic and discussion was valuable and what you'd like to hear more about in the future so that we can continue to give you valuable, useful, and actionable information so that you can become a more resilient organization. Your feedback is terribly important to us. That helps us to continue to deliver content and conversations that you've come to expect from Hub and that prove useful to you. On behalf of Corey, Christy, and myself, and all of Hub, thank you for joining us today and spending your time with us on this webinar. This now concludes our broadcast.